Monetizing Healthcare Real Estate conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Monica Chmielewski. Please go ahead.
Hi, thank you very much. Hello and welcome, everyone. My name is Monica Chmielewski, and I am Special Counsel with Foley and Lardner. I'm co-chair of Foley's Life Sciences Industry Team and vice chair of Foley's Healthcare Industry Team. I'd like to take this opportunity to welcome you to our Access to Capital, Monetizing Healthcare Through Real Estate web conference. We are very excited to present today's teleconference to you today and believe this is a timely topic for reasons to be discussed during the conference. Now, I'm pleased to introduce today's distinguished speakers. I'll start with, we have Fred Geilfuss, who is a partner with Foley and Lardner. Fred is in the healthcare group and is based in Foley's Milwaukee office. We have Nathaniel Ned Scheer, and Ned is Vice President and Senior Relationship Manager for Fifth Third Bank's National Healthcare Group. He is responsible for credit origination and cross-selling banking and capital market services to a broad array of healthcare companies in the Midwest and Rocky Mountain regions, including healthcare providers, managed care companies, medical device companies, pharmaceutical companies, healthcare information technology, healthcare distributors, and other healthcare sectors. Next, we have John Boley, and John is Senior Vice President of Acquisitions and Development for HSA Commercial Real Estate and HSA Prime Care. In his role at HSA Prime Care, John is responsible for sourcing, underwriting, and closing medical facility developments and acquisitions, as well as providing market and financial analysis, risk analysis, asset evaluations, and related economic modeling for Prime Care's healthcare real estate portfolio, as well as prospective medical office transactions. And last but certainly not least, we have John Wilson. And John is president of HSA Prime Care, which is HSA's commercial healthcare real estate group. John leads a group of very talented professionals specializing in healthcare real estate consulting, leasing, development, and property management. I would like to thank all of our speakers for participating in today's web conference. Before we start, just a few housekeeping tips for everybody's information. Today's conference will run approximately 1.5 hours, 1.5 hours. We are going to apply for 1.5 hours of general CLE credit for today's program. Any attendees from the states of New York, New Jersey, and Kansas that want to apply for CLE credit must fill out an attorney affirmation form and write down the course codes that will be given during today's web conference. Periodically throughout the web conference, I will announce the codes for you to write down. A form can be obtained by going to the materials section of your screen, and that's how you can find the attorney affirmation form. Electronic questions can be submitted during the broadcast by clicking the Q&A tab at the bottom of your computer screen, and we will have a live Q&A session at the end of the web conference. At this point, again, I thank everybody for their attendance and participation, and I would like to hand this over to Fred.
Thank you very much, Monica, and welcome to everybody. Today's topic is monetizing real estate assets as an option for healthcare providers, and particularly hospitals. And I'd first like to chat a little bit about the general 2014-15 outlook for nonprofit hospitals and why real estate monetization is something that they should consider. The financial situation for hospitals in the past few years has been less strong than it was historically. Overall, healthcare spending has slowed, and the rating agencies have put negative outlooks on the financial environment for healthcare providers, and particularly hospitals. And Standard & Poor's has a decidedly negative outlook. They mentioned, the rating agencies mentioned, worsening credit conditions, struggles to reduce costs, changing reimbursement methods, and the need for continuing investments as the principal causes of this. They point to patient volumes that will shrink and revenue growth will slow, that margins will tighten, that there will be continued rate pressure both from governmental payers as well as from commercial payers. And then the changing in reimbursement and the unknown levels of uninsureds through the Affordable Care Act implementation will be aspects that are going to continue to lead to this negative outlook. There also are projected to be lower Medicare payments. We're still feeling the effects of the impact of the sequestration, and there's also a reduced market basket increase from the Medicare program. So Medicare payments are expected to continue to reduce. As part of the Affordable Care Act, there's also a reduction in disproportionate share payments. Disproportionate share payments are rewarded to hospitals for treating a significant population of indigent patients, and they're being cut through the Affordable Care Act. Medicare actually will experience a 75% cut in disproportionate share payments in 2014 as mandated by the Affordable Care Act. This is a front-loaded decrease, and it really leads to a $17.1 billion increase through 2019, but it is very much front-loaded in the Medicare program. The Medicaid dish payments are also being cut, an average of over 4%. Those increases will continue through 2012, harming the revenue of hospitals that qualify for disproportionate share, which is often the larger, more urban hospitals. And the Medicaid decreases will continue and are not as front-loaded as the Medicare payments are. There's also an expectation that we'll see lower inpatient volumes for a variety of reasons. There has been a shift to the outpatient side of the business for a number of years, and that is picking up with the Affordable Care Act. We have short-stay hospital visits are now treated as outpatient observation visits and reimbursed as outpatient as opposed to inpatient hospital, with reductions in revenue as a result. This started with Medicare, but as is common, the commercial payers, managed care payers are picking up and following the Medicare's lead on this score and leading to a reduction in revenue. There's also been a significant move to eliminate avoidable admissions. This is part of the impact of the Affordable Care Act and some of the reimbursement strategies that they've implemented in there that overall have had an impact in slowing hospital revenue increases. Increased consumerism in the form of high deductible plans and making people greater participants in their own care and the cost of it. And this is having, I think, a significant impact in people being more careful about spending dollars on hospital care and particularly inpatient care. If there's a lower cost outpatient alternative, people are seeking it out because it means money in their pockets. We're also seeing volumes just down generally. I think wellness may have an impact on that. People are focused more on wellness. The increasing consumerism where people are monitoring their health is starting to have an impact. And we also have some trends that have occurred. Not too long ago, cardiac surgery was robust, and then soon it was learned that taking an aspirin a day can often delay or eliminate the need for cardiac surgery down the road. So there are aspects of care that have been changed that have led to decreases in volumes. And I think we're also seeing that the impact of the recession and the recovery from it still has had some impact on decreased volumes. Commercial rate increases have also been reduced, often following the government and reflecting also the market power of the larger managed care companies that seem to have more sway than they maybe once did. So overall revenue growth is probably used to be in the 5 to 6% range a year, and now it's trending to 3.5% or below. There are a variety of factors that have affected the lower margins as a result of the Affordable Care Act and a variety of other factors. We are seeing a movement to further physician employment, acquisitions and operations of practices, physician employment by hospitals lead to significant costs, investment costs up front, and ongoing high operating costs. Most physician employment arrangements are operated at losses for hospitals, frequently as they move a lot of the ancillary services that were performed in physician clinics into an outpatient setting. There also continues to be a significant information technology and infrastructure expenses. The electronic health record, the ICD-10 coding changes that's been delayed but is still scheduled to be implemented in 2015. Increasingly, hospitals are seeking to manage big data. There's a real move afoot to do that, and that leads to increased costs. And as always, the healthcare industry is a very capital-intensive industry that leads for significant capital expenses. We're also seeing a higher percentage of government-paid patients. I think a lot of this is a result of the recession we had and the slow recovery in employment. I hope this will go away over the next few years, but Medicaid has expanded significantly, even in states that didn't embrace the expansion of Medicaid as planned by the Affordable Care Act. And Medicaid, as everyone knows, is a very poor payer and something that harms hospitals traditionally. And there are a number of regulatory compliance costs that continue to arise. The government and key TAM plaintiffs continue to oversee what's going on in the hospitals and with healthcare providers. There have been significant healthcare compliance recoveries, and providers are expending large sums of money on increased compliance. Just recently, we've seen a dialysis provider pay $380 million in compliance as a result of a key TAM action in which the government joined into. A health system down in Florida paid $85 million for Stark Law violations. We saw another system pay $237 million or be charged with, found to being guilty for $237 million of false claim payments. So we also are seeing tougher corporate integrity agreements that require a variety of expenses to ensure compliance. Bad debt has also been a source of challenges for hospitals as we get high deductible plans where patients don't pay the significant copays and deductibles, the large copays and deductibles that they are supposed to. We also have seen changes in reimbursement methodologies. A large part of the Affordable Care Act, which many have attributed to the reason why the Affordable Care Act has had some success in constraining hospital cost increases, has embodied changes in reimbursement models away from fee-for-service medicine. We have value-based purchasing where a percentage is shaved off of Medicare payments that can then be earned back if you meet quality indicators. The pay-for-performance program creates incentives for better outcomes. We're seeing increased shared risk and capitation models where providers are becoming more like insurers in a variety of circumstances. The bundled payment program is one in which you combine in one payment both the acute episode and frequently 30 or 90 days post-acute, and you'll combine those with one payment so that there's real incentives to not provide more services and to bring costs in below the payment you're receiving. Accountable care organizations are also growing. There are over 300 HCOs that are participating in either government's Pioneer program or the Medicare Shared Savings program. And we're also seeing other variety of products that the CMS has introduced to encourage participation in ACOs, which have led to significant reductions in fee-for-service behavior and less services being obtained. And we're seeing commercial payers really embracing ACO models. In my practice, I'm seeing that almost on a daily basis, where one of the large commercial payers has a quality program in which they, for lower unit pricing, is providing for increased reduced payments and perhaps a share of savings. Medical homes are also a thing that we're seeing more of, where there's a group or a home focus on how care is provided, more utilization of PAs and NPs, and we're seeing care being managed much better on the front end. So these are there are also a number of challenges created by the transition from fee-for-service medicine to an outcomes-based medicine. If you have your foot in where a system is participating in both fee-for-service medicine for 60% of their business and 40% of their business is in trying to restrain cost increases and focus on reducing costs, there really is some uncertainty created as to what the best model is, and it's very difficult to manage through. The ACA impact has also has had an impact. The impact of the exchanges, I think, is still unknown. We're signing up now for the second year. What does that pool look like? How is it going to work? So these are some challenges. We have the uncertainty created by the Supreme Court's decision to take that created by the language in the Affordable Care Act that subsidies are only available to state-run exchanges, and that just creates some uncertainty as to how that'll be resolved. Also in the exchanges, the bronze and catastrophic levels have very significant co-pays and deductibles. These are generally signed up by the people signing up for them are the young healthies, typically, who don't consume a lot of health care, but if they do, they likely are not in a position to pay their co-pays and deductibles. As we mentioned earlier, there's an increase in Medicaid. And on the other side of the coin, and what got the hospital support for the Affordable Care Act, is that there's a promise of more insured business, more covered patients. So a number of the uninsured who really left their hospital bills go unpaid now have some kind of coverage, either through Medicaid or through the exchanges. So that's a positive for healthcare providers. And there's been just a consistent focus on the need to reduce expenses. I think the data on the cost of the U.S. of healthcare in the United States has really gotten to people. Businesses are very focused on reducing their healthcare spend, and it's had an impact. But through it all, the capital needs remain. I think some capital expenditures were delayed during the tight years of the recession, but we also see needs for capital focused on infrastructure for the changing reimbursement methodologies, ensuring that you have the ability to have an electronic medical record that extends well beyond your own organization to others that are participating in the network, significant costs involved in measuring and reporting on quality, and profiling, physician profiling that often goes with the ability to make money in a capitated or fixed fee environment. Physician practice acquisition and alignment arrangements are still continuing, accelerating in many parts of the country. And as mentioned before, they have expenses both in the acquisition and in operating them. We're seeing a number of IT upgrades through meaningful use, the ICD-10 coding, and managing big data have all had an impact. And ambulatory care expansions, the move to outpatient care has really contributed to a need to expand medical office buildings and the like. And throughout it all, there are continuing hospital drivers of buying the latest medical equipment, upgrading their facilities, and staying at the cutting edge. This has been a consistent pressure for as long as I've practiced in the healthcare field, and it hasn't gone away. So what is real estate monetization? It's really converting your real estate assets into capital that can be used for other purposes. As this economic and financial environment suggests, you need to look at other means of obtaining capital to satisfy these challenging times. And one key aspect to consider is your real estate. Hospitals have very large investments in real estate, and can these real estate assets be utilized or converted to capital for usable other purposes? As our speakers will speak today, there are a wide range of considerations that providers will want to go through as they consider utilization of real estate. Is it right for your hospital? What real estate should you consider utilizing? How do you go about it? How do you find a partner? What structure do you use? And how do you ensure you keep control to the extent you can over those real estate assets? There are also a variety of other issues that will be addressed in the process. One thing, though, to talk about is in all healthcare transactions, there are a variety of legal and regulatory issues to consider that can have very serious consequences and a huge impact on real estate transactions. First and foremost are the Stark Law and the anti-kickback laws, both of which apply to real estate transactions and can create some real problems if you're not careful. These are two separate laws, but there's significant overlap in them. The Stark Law is a civil law. You need a physician involved. You need designated health services involved, a list of specific services. And it's a strict liability statute. If it applies, you are liable unless you fit completely within an exception. And we've seen some significant recoveries of Stark Law and anti-kickback statute. Anti-kickback statute is an intent-based statute where if you're paying to induce a referral, there's a potential criminal violation. And again, it's criminal. We've seen some significant recoveries involving use of real estate, often involving lease issues and leases not being done properly. A system in the western United States paid $25.5 million in penalties involving improper leases, not at fair market value or not signed up in time. Another system paid $16.5 million over too high a lease rate. There have been other recoveries for not having signed leases, just not doing the blocking and tackling with a lease that you need to do. So monetizing real estate by moving real estate out of the healthcare provider into the hands of a developer can frequently be a real positive consideration in monetizing real estate. These aspects of ensuring that the leases are signed as is required by the Stark lease exception, that the lease is at fair market value, percentage rent issues that often are problematic for healthcare providers to pay, go away if you have a commercial real estate lender, developer as your landlord. A variety of, we have a Stark space lease exception and an anti-kickback safe harbor that are very important to follow and monitor because, again, they can have large recoveries. One source of real estate that's often usable is when a hospital buys the clinic and the practicing physician's practice, they'll often get the real estate that may be owned by those practicing physicians themselves. They'll want to stay in that facility at least for a while, and leasing from insiders, other physicians, can create some real challenges. Do we have the rent at fair market value? Are we overpaying the doctors to reward them for referrals? These are real challenges and really good opportunities to sell out those clinics to developers that will then own them, and if you need to use them, continue to lease them to you. Fair market value is a driver, and commercial reasonableness are significant drivers in these exceptions and safe harbors, and they're important to follow. And one question is, are you leasing too much space? This can be an issue. Build-outs, and who pays for the build-out? Frequently, I've seen physicians come to hospitals and say, gosh, we're building a practice, we're starting out, can you give us a benefit on the rent for a short period of time? And we'll pay a little more later on. And working through that can be a challenge. And increasingly, we're also seeing that there are hospital-based space where the hospital wants to operate it as provider-based for the increased reimbursement opportunities that are available, and those can create some challenges as well. And we have enforcement. If a physician that's loyal to the hospital is not paying rent, is the hospital going to sue its physicians? The law may require it, or may require significant enforcement activities be taken. So really avoiding these administrative burdens can be a significant reason to consider monetization transactions. And just avoiding the requirement that you have to say no to large volume referral sources can be a significant benefit. I still run into physicians thinking they are entitled to some deal because they make large referrals to a hospital. And you need to, you can avoid those if you don't own the real estate. We also have some shared space challenges that, again, are very simplified if a developer or someone other than the hospital or another provider owns the facility. Other considerations to take in mind in selecting the real estate is whether the real estate is property tax exempt. The property tax exemption can be a large economic benefit and may drive you to select the proper properties. But we've seen some activity in a variety of states where people are starting to say that the property tax exemption may be challenged and may not succeed for a long time. Critics say the value of the tax exemption exceeds charitable care provided, and they point out, critics also point out that hospitals are big recipients of police, fire, and other public services and really should be paying for property taxes. In 2010, we saw Illinois strip the property tax exemption from a downstate hospital, and they've taken actions to deny tax-exempt status in Illinois to 3 other hospitals. And increasingly, even with hospitals, we're seeing local communities requiring payments in lieu of tax obligations in order to do zoning approvals. We also have outstanding tax-exempt debt issues. It's very important as you consider monetization transactions to consider the impact of the transaction on your any tax-exempt bond proceeds that you are utilizing. If you use tax-exempt bonds, that should be a red flag issue and say, I better talk to the bond counsel and figure out a strategy so that the debt doesn't become taxable because of a sale or a development that puts the property to different use. We always have dealt with the management agreement bad use issues. In essence, if your property is used, has been financed with tax-exempt debt, it has to be used by a tax-exempt user. And there even physicians coming into the space to serve as medical directors or provide other services can lead to real challenges on that. And revenue procedures 9713 has been a key focus. Recently, it was amended just within the last month or so to create some more flexibility. But those are issues you're going to want to consider as you decide how you're using real estate that's financed with tax-exempt debt. And there are some significant accounting issues that you'll want to ensure that you understand as you go into a transaction, and that you probably get with your accountants. The rules, there are 4 conditions that are typically involved, dealing with the length of the lease, not exceeding 75% of the estimated economic life, whether there's a transfer of ownership of the property at the end of the lease, whether there's a bargain purchase option at the end of the lease, and that the total value of all the payments cannot exceed 90% of the fair market value of the assets. These seem like they're mechanical, objective criteria, but the way they're applied is not. So depending on if operating lease treatment is critical to the hospital, you want to get with your accountants at the front end and make sure that you don't have problems. Well, that concludes my remarks, and I guess I'll, do I push it back to Monica?
Certainly. Thank you, Fred. I appreciate that. And now I will turn this over to John Wilson and John Foley to talk about using real estate to access capital.
Thank you, and thanks, Fred. Fred provided an overview of the changes and challenges hospitals and providers are experiencing. Hospitals are facing unprecedented pressure to reduce costs while improving the safety and quality of patient care. What we want to look at are of the current trends which are affecting capital planning, real estate capital planning, and space requirements for hospital and healthcare providers. You know, we have not seen a one-size-fits-all strategy. Many hospital systems embarked on a hub-and-spoke ambulatory program years ago, well before reform. We're seeing variations of this strategy driven by many factors. The front and center are regulatory, such as Accountable Care Act, and as the government works out the kinks, it is expected to ultimately bring millions of newly insured. As Fred indicated, the Accountable Care Act also shifts the method of payment from fee-for-service to a value-based payment, and this is tied to the quality of patient care, and it's a driver to a new approach that a lot of the systems are looking at, a new approach in the delivery of care. Many are shifting to the medical home model, and although this was once a dot on the healthcare landscape, it's growing significantly. And the design impact of this on real estate, basically the medical home model is a team approach where a primary care physician leads a core team of physician and specialists handling the care of a patient. The primary care physician coordinating the care. The design of the space is built around flexibility and collaboration amongst the care providers. It eliminates the silos. Spaces are organized with a center pod, with team tables for the providers to not only set up reports, set up computers, but to collaborate on patient care. The space would involve or provide exam rooms that are flexible, that could house a primary care physician in the morning and a specialist in the afternoon. There's talking rooms within this space. These for face-to-face interaction for like a dietitian, and also group meeting rooms where a single care provider could meet with several, maybe 8 to 10 patients with similar conditions like diabetes. Now on the space, you're looking at a larger footprint, larger tenants, deeper space. And we're also seeing consolidation. The level of merger and acquisition by hospitals reflects really the hospitals look to gather the economies of scale, and as the New York Times chart demonstrates, there's been a significant increase in this activity. The drive, of course, is to reduce costs and manage financial pressures through these economies. Hospitals have been purchasing and partnering with physicians also, anticipating physician shortage, as well as achieve clinical integration. And as the chart in the lower right-hand corner illustrates, there was a spike in the mid-90s for physician employment. Hospitals at that time had significant operating losses due to the physician arrangements. Today, hospitals are incorporating more incentives and expectations of physicians as part of their employment. These expectations, such as quality and outcome measures, are really in response to the Accountable Care Act. This cost and consolidation, from a real estate perspective, we're seeing larger tenants, larger spaces, and space requirements. In demographics, we've heard about the aging population and the silver tsunami, the upwards of 10,000 baby boomers a day turning 65. The impact of this on real estate is the visits to a doctor's office or to the doctor increase substantially, virtually doubling between the age bracket of 45 and 64 and 65 and 80. And of course, from a real estate perspective, this puts a strain on not only the system, but the system's space. Technology is another trend, and innovations continue to improve procedures. And as mentioned earlier, more and more are moving to an outpatient setting, which the upper slide demonstrates. The shift has and will continue to increase the need for outpatient procedure space, both on campus and off campus. We see many hospitals refining the hub and spoke ambulatory program started years ago. And this could be from small clinics of anywhere from 8,000 to 10,000 square feet to a hospital-like concept. This addresses the increased outpatient needs for tenants. The small clinic may include an urgent care facility with a primary care presence located in patient-convenient locations, really to provide low-cost, efficient care and take this space off campus, even in some retail settings like a strip mall. Also, there's been a significant growth in mini clinics, such as the CVS Minute Clinic. Visits to these clinics have tripled back in 2007 to 2010, and they're expected to double again from 2012 to 2015. And at the other end of the spectrum, you have the multi-specialty center. These buildings could be anywhere from 60 to 150,000 square feet, even 200,000 square feet, and can house urgent care or even a full emergency department with labs, diagnostics, group education, primary care, specialist, ambulatory surgical center. These buildings are stressing integrative medicine, pretty much a one-stop for patients. Different from the typical MOB of the past, where you would have possibly a common corridor linking individual physician suites, each suite with their own waiting areas, their own exam rooms, nurses' stations. The new buildings, the buildings housing these medical home models would have less minimal common area and a greeting area whereby a patient would arrive and in most cases would have pre-register, and upon arrival go to the common check-in and basically receive a waiting room number, and at the time of their appointment go directly to the waiting room. Technology, as we mentioned earlier, will continue to impact healthcare development, and in turn, buildings have to be built to house and be flexible to accept new technologies. Developers today are concentrating on flexible designs to accommodate this fast-moving technology. One of the areas of technology is really the point-of-care diagnostics. And in the lower in the lower right-hand corner, you'll see some of the electronically communicated devices. Patients, as far as accepting the use, percentages trail off from email correspondence with a 69% acceptance, to online chat at 49%, to texting at 45%, and 40% at mobile health applications. And it's this application where technology is heading. In the future, handheld, non-invasive electronic devices will be available to diagnose patients, possibly better than a panel of doctors. This will help alleviate the stress in the system, the stress in the real estate system, and facilities. Capital markets. With most hospitals looking to control expenses and protect their balance sheet, strategy and implementation is what the rating agencies are looking at. Many hospitals have made cuts addressing low-hanging fruit, and as we've talked about, purchase physician groups or merge or acquire a once competitive hospital. As providers look to implement ambulatory strategy today's pricing market is very advantageous. As you can see in the graph up top, we are back to pre-recession levels of transactions as far as sales of medical and healthcare facilities. Though a large percentage of these facilities have been physician-owned or private, we do see a renewed interest on the part of hospitals to look at asset monetization. Today's historic low interest rates are driving aggressive real estate pricing. Real estate also constitutes, in many cases, the single largest balance sheet asset for healthcare providers. So tapping this as a source of capital is expected to increase in the years to come. In the lower half of the chart, HSA did a self-survey of healthcare providers and executive teams throughout the Midwest in the past year. And on the right-hand side, the question asked was, do you have plans to develop or build new facilities across the Midwest in the next 12 to 18 months? And as you can see, between yes and maybe, it's a 75% response to leaning towards development. On the right-hand side, the question was, as a hospital or health system, are you seeking to own more or less of your medical office buildings? Own less is at 58%, own more at 42%. So what we're seeing is the mindset that hospitals have today is that more facilities are needed, and as far as ownership, they're open to not owning at almost 60%. And the two main reasons given to us for this was really, one, to focus on core operating goals by the hospital, and the consolidation, the second being the consolidation of real estate resources. At this time, we wanted to look a little bit deeper into asset monetization, and I'm going to hand off the mic to John Foley.
Thank you, John. Basically, there are really two forms of asset monetization, two main forms. The first is the sale of existing or current real estate that's owned by the organization, and second, new development. I'm going to go briefly through the sale of existing assets. and talk about that, both the key consideration as well as the process, and then I'll hand it back to John, who will go over new development. With asset monetization and the sale of existing assets, often you're looking at the sale of existing property and the potential lease back of a portion of that property. So in that situation, you're really looking at the new leases for occupied space, really at market rents, and looking at the terms of those leases within the space. Some of the key considerations of asset monetization are the cost of capital. And really what that means is really looking at their competing capital needs within the organization, as we've discussed here today. And you're really looking at the opportunity cost of investing in different capital requirements within the organization. So when looking at real estate, you really need to look at if you're going to continue to own real estate or buy real estate, you really need to look at what you're giving up within the organization. And with the cost of capital, it's generally not the borrowing rate for the organization. There's a limited capacity for a borrowing in the organization. What you really need to be looking at is the average return on investment for other capital investments within the organization. So that's looking at, what could you generate for returns on your investment, and say, if you're going to look at buying a new piece of equipment, medical, let's say an MRI machine, what revenues are generated by that MRI net revenues compared to what it costs to invest in that particular equipment. And you need to match that return on investment or compare it to what you could potentially be earning with real estate investment and putting your capital into real estate. Other considerations are control. Typically, ownership is going to have a greater level of control. However, you can also, with asset monetization, with selling off to a third party, there are different forms of control that can be utilized. Within a ground lease document or a space lease document, certain control provisions can be written into those documents. Some examples, purchase options, rights of first refusal, that if the property were to be sold, the hospital or physician group would get the first right to look at that or purchase that property at the price. Use restrictions, tenant restrictions. So there are a number of ways to put control provisions within an asset monetization strategy. Also, another consideration is redeploying capital to core operations. One aspect of asset monetization is what you're really looking to focus the resources into the core operations of the organization. Real estate generally is not a core piece of a healthcare operation, so that is one aspect you need to consider. And then Fred earlier discussed Stark regulations, the anti-kickback provisions, and really the sale of real estate assets could potentially alleviate some of those risks. I'd like to go through a little bit on asset monetization process. Really, when considering asset monetization, one of the first things you really want to consider or look into is really defining the goals and objectives of what you're trying to achieve through the monetization. What are the parameters that really define success for this transaction? You need to really look at start out with really looking at the strategic plan for service delivery. What's the outpatient strategy? Identifying where the core markets are, where the growth areas are, growth service lines, new markets that the organization would like to look to get into. And then next, after that has been accomplished, you really want to look at property inventory and going through, identifying all the real estate within the organization and classifying those properties within the organization. So you see in the diagram here, really identifying what's a core asset within the organization, and what is the non-core and what could be potentially sold off. So on this chart here, you'll see core assets are typically the more specialized properties. The hospital would be considered a core asset, highly specialized building, a surgery center, generally identified in core, a freestanding satellite emergency room, cancer center, again, highly specialized properties. Whereas then on the non-core, you look at things like medical office buildings, administrative buildings, a rehab center, things of those nature, which have a lot lower acuity of care. And when looking to sell, typically you're looking at the less specialized facilities are going to be the most attractive within the market. However, as investors get more familiar with healthcare real estate, they are jumping into more specialized facilities. So there, a number of cancer centers have been both monetized as well as developed by third parties, and the same with surgery centers. So after the property inventory, within that you also need to look at the real estate within that property inventory and look at also how much of, note how much of the building is occupied by the provider. And then next we want to look at how do those existing properties fit within the strategic plan that you defined earlier, and really matching up the real estate with the strategic plan. John talked a little bit about changing dynamics of the interior space and the medical home model. Does the existing real estate fit, the new patient home or patient home model? Can that facility be retrofitted? Does it have the flexibility to be adjusted to those new needs or more efficient floor plates or floor uses? Next, you look at the financial decision value structure, and this is really looking at structuring the actual lease terms, or if a part of the building is going to be leased back, you're really looking at how the leases should be structured. Rents, term, are there any capital needs within the building that you would like to have addressed? Such updates to the lobby, updates to other parts of the building. That should also be factored within, within the transaction. Also here, you're looking at the control provisions, the potential rights of first refusal, purchase options. It should be noted that a lot of those control provisions may come with a trade-off, that they do have an impact on pricing. A potential third-party acquirer would generally look at, would need a higher level of return, or they would have made higher perceived risk if there are a number of purchase options or other control provisions on there. So there may be a trade-off that you'll need to consider. And then next is the implementation. Really identify qualified purchasers, assembling the property information for purchasers to go through and understand the properties. And then it's going through that process. So key to the whole process really is to have, from the very beginning, is to have a real estate advisor to help guide you through the process. The right advisor really should be an extension of your real estate team and really be brought on board in your organization and fit right in with that. So with that, I'll hand it over to John to talk about third-party development.
Thanks, John. In coming out of the slowdown after the recession and the implementation of the Accountable Care Act, developers and hospital executive teams have been busy evaluating ambulatory strategies and development. Systems are weighing the impact of recent acquisition either a hospital or a physician practice. Many new employed physicians may have come with real estate, either in buildings that they have owned and now leased back to the hospital or have sold to the hospital. There's potential overlap. So as the team evaluates and identifies target areas for services, it takes into consideration the delivery of care model and the strategic plan for ambulatory services of a hospital. And the real estate development team needs to address these goals and objectives of that ambulatory strategy plan. So one of the keys to, or a key consideration for a development plan is a defined process. This process keeps the outcome aligned with the goals and objectives. We'll come back to process in a bit, but there's the lease own analysis, which John touched a little bit on with monetization. You run through the same analysis or a similar analysis for development, looking at the pros and cons of ownership. Certainly there's the upfront capital that a third-party developer could provide. There's the Stark Law. There's the real estate risk and management that you could be alleviated of. Looking at the opportunity cost of the capital that you're not spending on the building and applying towards a operational need. And then also looking at property tax impact. With a third-party owner, there is the real estate tax to look at. You do relinquish some control, and those control issues can be handled through either the lease document, or if it's an on-campus building, maybe through a ground lease document. Physician ownership is another area where a third-party developer or provider can really come in and be beneficial. Many physicians look to real estate as a possible for ancillary income, and a third-party developer could provide this and alleviate any Stark-related issues. The speed to market and expanding your team, third-party developer really could bring speed to the market when time is money. Using the capital and experience of a third-party developer could help both offensively and defensively acquire and get to target markets quickly. Back to the development process. As John indicated in exit monetization, we really promote process, and in this six-phase development process, the initial phase is scope definition, and in this phase you're basically coming together with the executive team and reviewing the project parameters and making sure they're in line with the strategic delivery of care. You establish location criteria. How will the services that the hospital offers impact the location? How does the hospital attract first-time patients? You identify any budgetary constraints, determine project desired outcomes, and the product of this phase is a written goals and objectives for the project. In phase 2, feasibility, the team is testing or vetting the goals and objectives against market input, making sure the boundaries of the target market are realistic, the types of service and travel times aren't unreachable, such as a primary care physician. The patient will travel less time than, say, a specialist. Also, consumer perception of a community ways. There's physical and psychological boundaries to sites, expressway tracks, etc. any special requirements, an MRI, if you're building a cancer center, the area for a vault. You review entitlements, establish the team, and the conclusion of this phase would be the team's findings summarized in a strategic direction for the provider. And then schematics is a review of the potential sites, existing facilities, building specifications, and finalizing the scope. The deliverable at this phase is a site selection, project scope, and schedule confirmation. In the design and development phase, programming and confirmation with user groups is undertaken. Engaging with the staff is an excellent resource. Here we look at material selection, engineering coordination, and the outcome of this phase is the final design and confirmation on a budget. In construction phase, you finalize drawings and the bidding process takes place. This is where real dollars are realized. Finalizing entitlement and permitting, commencing construction, weekly meetings to reconcile the budget and schedule, and the outcome of this phase is occupancy. And then the final phase is post-construction punch list. We measure the meeting the goals and objectives set forth in phase one. And the process is success is driven by the early phases, really spending the time and energy up front discussing and planning. This process, of course, can be adjusted and applied to various real estate requirements. We're currently working on a evaluation of a project in the Midwest, and I'm going to hand it back to John to walk you through a case study.
So we wanted to briefly touch on a project that we're working, as John said, in the Midwest. The project it's still ongoing, but I think it's very timely for kind of what we're seeing a lot of in the market today. We're just to give you some background, a health system recently purchased a physician practice, and with that came 3 locations that are owned by the physicians. The hospital stepped into leases on each of those locations, and really what it's brought to the head is that there's some overlap within those locations. And also the leases are coming up now for renewal, and the hospital really wanted to look at their overall outpatient strategy, strategic planning in these markets, and how these facilities fit within those plans. So I want to give you a snapshot of, as I said, the project is still ongoing, but I want to get a snapshot of kind of the process and the evaluation that we went through and the direction that was identified. So as I said, it's the hospital system recently bought the physician practice, 3 locations. All of them are off-campus outpatient buildings located within a 12-mile corridor from the hospital. One facility, 20,000 square feet. All of them are located within a large or major metropolitan area. But they're smaller markets within that metropolitan area, out on in the suburbs, far suburbs. The first facility, 20,000 square feet, primary care clinic. Second facility is about a 10,000 square foot location with primary care and imaging. And then the third location was a larger multi-specialty medical office building with an ambulatory surgery center comprising approximately 100,000 square feet. Most of these locations, the hospital had multiple. In one instance, one of the markets had not only the small primary care clinic, but a small rehab clinic in a separate location. The leases were assumed by the hospital, and now they expire within 2 years. So they really wanted to look at the real estate options. And whatever decision is made by the hospital will have a significant impact on the physicians, since they are currently owners of the real estate. And if the hospital were to choose to leave those locations, the value of the real estate would be significantly negatively impacted. So first of all, what we first obviously went and sat down with the hospital and went through goals and objectives, what they're trying to achieve for this project. And next we went into the market evaluation of really looking at the building locations and the markets that they were in, overlapping services, where the duplication were, and also looking at, potential, for consolidation or economies of scale. We looked at existing site flexibility. Can the building be expanded? Looking at the floor plate, can it accommodate some of the new requirements for floor plans and a physician home model, or medical home model? And then also looking at operational performance, how each facility is done. Also, is it a growing market? Is it a declining market? And what the service mix for each of the locations were. And then also factoring in or looking at the system's short-term objectives and long-term operational objectives for these markets. And then for each of the locations, we looked at what are the occupancy costs for the location, looking at both base rent as well as operating expenses. Operating expenses, real estate taxes, janitorial, cleaning, site maintenance, all those types of factors. And looking at those and comparing those to industry averages, as well as what the averages are in the market and where those buildings are located. Then for each property, went through the various real estate options for each property. Number one, stay and extend the current leases, move, find another building in the market, develop a new building, or looking at perhaps closing and consolidating operations. So here's just an example of this is for the larger 100,000 square foot facility, and we looked at for all the properties. We looked at real estate factors: adjacencies, access, visibility, parking, competition in the area, wayfinding signage, and went through each and ranked each of those items on a scale 1 to 5, with 5 being excellent. And then also noted any significant issues with the property. For the larger facility, one of the big challenges because of the site topography, there's multiple entrances. However, the facility also was an older facility, developed and expanded over a number of years. First developed in 1989 and then expanded a number of times. So the wayfinding and the floor plate of the facility was a real challenge for this property.
If I may, forgive me, I've been asked to briefly interject here and announce the first program code, and I'll turn it right back over to you, John. My apologies. But for people, for CLE purposes, the first code is EAFN. Again, that's EAFN. All right, thank you. Sorry for the interruption, John. Please continue.
Okay. And next, for all the locations, we looked at, as I said previously, a cost comparison matrix. Number one, what the current situation was, what a market rent was or is, and then what a potential rent would be in a new development. One of the key pieces in this is making sure you're comparing apples to apples. If you're going to stay in the current location, there presumably would not be significant investment required to build out the space to the desired application. And then, but if you were to change and move it to another building, there would be interior build-out costs to make the facility what was desired. And same with the new development. So an adjustment needs to be made in terms of those rents. And this was for the larger building, and as you can see, the current rents were significantly above market, as well as a potential new development. So, in just wrapping up our main findings for this portfolio of properties, for the small buildings, the 2 primary care clinics, we found that the buildings are they're generally pretty small floor plates. They're pretty outdated or inefficient design. Floor plates are small, the 2-level facilities for both of them, and that didn't provide much flexibility to the users. The rents were above market, as well as the operating expenses for those facilities. However, they are functional, and really driving down into those costs, it was really determined that it's more cost-effective to stay at the current locations at the present time. There's an economies of scale issue there. These are small primary care clinics. They're generally, on a new development basis, they're fairly costly to build. So for the small facilities, it was decided, or the direction that we have right now, is to really look at extending the terms of those leases at market rents. For the large multi-specialty building, the building is really in a great location, high traffic, excellent visibility, inefficient because it's been expanded over a number of years, and the floor plate's not very conventional. So really, with the larger facility, when you're looking at the costs associated with a new development, there's significant economies of scale and efficiency gains that can be achieved through a major retrofit or new development. So really, it's looking at the existing facility and comparing that to a new development. Can the new facility, or can the existing facility be, with significant investment, can it be retrofitted to make it, the floor plate more efficient and a lot more user-friendly in terms of wayfinding and things of that nature? And then also comparing that against just a new development. What are the costs, comparison between those two? And then also looking at possibly consolidating some of the services to the new hospital that's nearby. That would be moving the ambulatory surgery center component to the hospital and downsizing the actual space need at that facility. And as I said, the project's still ongoing, but we're excited to be moving and identify the direction and moving in a new direction on that. So I wanted to hand it back to Monica.
Oh, thank you, Don and John, for all the information. Very informative. With that, Ned Shear, I'm going to turn this over to you to talk about this topic from Fifth Third Bank's perspective.
Okay, thanks, Monica, and thanks, John and Fred, for your comments. I'll keep my comments fairly brief and click through a couple slides in the interest of time. But as you know, a common theme that Fred and John have mentioned, that healthcare systems capital is getting a scarcer resource in the current environment. Good news is that in general, for the right structure, banks are willing to lend in the current lending environment, and terms are generally favorable for borrowers. So I'll run through the tax-exempt taxable loan market, talk about the role of healthcare REITs and their access to capital in a way to monetize real estate assets for health systems, and then provide a couple examples. Well, certainly turning to the credit markets, the last 6 years have been interesting times for healthcare finance, and hospitals undergone some major transitions in the way they finance their capital. So it's really helpful to provide a little history here. Starting in 2008, we saw a tidal wave of refinancing as the auction rate structures failed and health systems needed to refinance their variable rate debt with letter of credit backed VRDNs. And then 2009 saw more refinancing as letter of credit backed VRDNs again ran into issues due to bank ratings downgrades amidst the worst of the financial crisis. And health systems either needed to replace their LC with a stronger rated bank or move to yet a different structure, which saw some of the rise in the NBQ direct purchase debt. So as this slide shows, you can see there's a general trend and decline in tax-exempt financing replaced to some extent by taxable loan volume and direct purchase loans. As rates remain low and LIBOR isn't that much higher than SIFMA, and taxable debt also allows for more flexibility in the use of proceeds, particularly some of the things that we've discussed earlier, including funding physician acquisitions and some of the ancillary services that hospitals now need to move into, along with the IT spend, has driven the increase in the taxable loan market. But you can see overall that the total volume of financing for hospitals over the last 6 years has declined, given the overall capital constraints under lower inpatient volumes and risks of reimbursement under the Affordable Care Act. So hospitals have generally had to be more prudent with their capital and therefore evaluate refinancing or financing activity more prudently. So banks' balance sheets have now fully recovered from the stress of the Great Recession, particularly among the largest banks. Loan growth up until very recently has remained relatively flat as companies delever and hospital systems have deferred capital projects, as I mentioned earlier, and the overall slow growth in the economy. The direct purchase bonds have provided a good avenue for banks to utilize their balance sheet and attract funded loans. Banks currently hold $425 billion of direct purchase municipal debt, which is up from $225 billion in 2009. And as expected, letter of credit backed VRDNs have declined by a similar amount, $186 billion, as many of the letter of credit backed structures have been replaced by direct purchase bonds. Direct purchase bonds do have several advantages over LC-backed VRDNs, including removal of put risk due to banks' rating downgrades, and typically longer tenors than letters of credits. You'll see tenors out to 10, even 15 years on a direct purchase bond versus the typical 3 to 5 year on a letter of credit. Direct purchase bonds also have advantages over publicly issued debt, including lower issuance costs and fewer disclosure requirements. It would also be helpful to provide a loan market update. We provide, as Monica mentioned at the outset, we provide financing to a broad range of healthcare companies, so it might be helpful to address the broader loan market. Loan activity this year is the best it's been since the Great Recession, driven in large part by increased M&A activity. As noted even in today's Wall Street Journal, 2014 has been a strong year for M&A. A number of large M&A transactions have been announced this year, particularly in the healthcare industry, such as Medtronic's acquisition of Covidien, Zimmer's acquisition of Biomet, and yesterday's announcement of activists acquiring Allergan for $66 billion, just to name a few of the headline transactions. Despite some choppiness earlier this fall, the low interest rate environment has driven investors to search for yield. Therefore, capital inflows into the high yield investment funds and collateralized loan obligations and other loan vehicles, along with companies flush with cash, has driven plenty of capital to fund acquisitions. Investment-grade bond issues are also having a record year to date, with issuance already topping 2013's record year of $982 billion. Again, the issuance has been driven by low interest rates, companies implementing share repurchases, and increased M&A activity. I'll briefly go over a recent direct purchase placement success story. Fifth Third was involved in this transaction earlier this year for a Midwest-based health system, which is rated AA3 by Moody's and AA flat by S&P. the health system was looking to refinance $113 million of total debt, including some higher coupon fixed-rate debt and letter of credit-backed VRDNs. Fifth Third was one of two banks chosen to provide direct purchase bonds, with us holding the $72 million Series 2014 A bonds. Pricing and some of the key terms of direct placement included pricing at 67% of LIBOR plus a grid-based spread based on the system's ratings. Tenor was 10 years, and financial covenants and reporting covenants match the system's MPIs. So the key takeaway here is that the attractive financing is available for stronger rated systems, particularly when the bank has a strong relationship with the issuer. So turning now to healthcare REITs, as we've been focusing on ways for health systems to monetize their assets. Healthcare REIT, there's many healthcare-focused REITs that have developed recently, and their stock performance has performed well, along with other access to capital, can provide a good avenue for health systems to monetize their non-core real estate. For example, REITs, as I mentioned, healthcare-focused REITs do have had strong access to capital in the increasing equity and with increasing stock prices and the low interest rate environment. For example, one of my REITs has already issued over $2.5 billion of equity and debt capital this year to fund its growth in acquisitions of real estate properties. While senior housing and post-acute facilities are the dominant focus of most healthcare REITs, MOBs and other hospital-related assets are an important component of many REITs' portfolios. Several REITs have MOBs and ambulatory surgery centers as their primary focus, such as recently formed Physicians Realty Trust, which went public last year, and Medical Properties Trust, which focuses on inpatient rehab facilities, long-term acute care hospitals, and even acute care hospital real estate. So some of the factors driving real estate's or REIT's interest in MOBs and ambulatory surgery centers or other outpatient hospital real estate is that they've seen, obviously, as others, my colleagues have mentioned, an increase in outpatient services, hospitals' acquisitions of physicians' practices often coming with non-core real estate that they are looking to divest. Hospitals are more capital constrained, as we've discussed earlier, under lower patient volumes and reimbursement rates. REITs can provide a way for hospitals to monetize their non-core real estate. And last, REITs have been able to access the capital markets through several avenues. They're actively seeking healthcare properties to drive growth and have driven pricing up for many healthcare properties. This next slide just shows some of the recent transactions that have occurred in healthcare real estate, with the top list focusing on the MOB market. You can see cap rates have ranged from 7.5% to roughly 6% in the recent transactions. So I'd like to turn to a case study that we were involved in recently. Fifth Third had a loan out to a MOB that was owned by a 22-doctor orthopedic group that was also the primary tenant. The building was constructed in 2007 and financed through an $8 million, through a taxable taxable bond issue with and Fifth Third had an $8 million letter of credit that supported that taxable variable rate bond. We also had the floating rate bonds were also swapped to fixed, and we were the swap provider. And since that was entered into 2007, and rates have substantially declined since the swap was entered into, it was substantially underwater. And earlier this year, as I mentioned, this publicly held MOB-focused REIT entered into a letter of intent to acquire the medical office building and approached Fifth Third to retain the existing financing structure due to its low all-in cost and amortization. Some of the key challenges that we discovered early on was that, first of all, with the swap underwater, it would add substantially to the transaction costs if it couldn't be rolled into a new financing. The existing financing structure that we had with the physician-owned MOB included guarantees from the physician owners, and our bank's underwriting group requested similar level of guarantee from the acquiring REIT. We also required appraisal review and 60-day bondholder notifications and legal documentation required delays in closing the transaction. So ultimately, the REIT determined it was best to utilize its corporate revolver and credit line to acquire the property, given the cost, timing, and complexity of keeping the existing financing structure in place. So the key takeaway here is that REITs actually can have greater access to capital at their corporate level, as lenders are more willing to lend to a portfolio of real estate assets than a single property. And revolvers can provide a more simplified structure than some of the things that we had currently had in place with a taxable variable rate bond supported by a letter of credit. A second case study that we're involved in currently involved a hospital prospect who was looking to refinance a portfolio of real estate assets, including a medical office building and an outpatient care center that the hospital owned controlling interest in, along with a physician group that the hospital system actually also owned. Our proposal required some level of support from the hospital in order to close the financing, ranging from a support agreement to a direct guarantee or inclusion of the hospital as a co-borrower on the mortgage. Our tenor and pricing options that we offered in our proposal included 7 or 10 years, LIBOR plus a spread depending on the maturity. We also offered fixed rate options in our portfolio with an amortization of 20 years. Our covenants on the financing proposal included fixed charge ratio and reporting requirements for both the hospital and the MOB. Our other requirements included, of course, a new appraisal, real estate due diligence, lease maturities beyond the loan tenor, and hospital support of the physician lease. So again, some of the key takeaways here are that support requirements would have prohibited the hospital from considering the debt off balance sheet, and so therefore the hospital could have evaluated some other financing alternatives, including a direct purchase facility under structure that, like we discussed earlier, with the hospital as obligor, or even selling the property to a REIT and maintaining the control and use of the property through a ground lease. We've also provided some recent hospital financing activity, but again, in the interest of time, I won't go through those, but can be included in handouts. So with that, I can turn it back over to Monica for any questions.
Thank you very much, Ned. And I'll also, at this point, announce the second code for CLE purposes. That code is the letter GJQL. Again, the second code is GJQL. And now I will ask, I see one question that has popped up in our question and answer box here. If any of the listeners have questions, please feel free at this time to submit them. Otherwise, we'll start with this one question and then look to wrap this up. So the question is, and I will turn this over to Ned or to John or Fred, feel free to jump in. And the question is, what constitutes good documentation of fair market value for lease terms with physicians? Is there anybody who would like to start off taking that? I'd be happy to, I'll give a little bit of information on this. I can tell you that when we're looking at leases and hospitals or other providers are entering into leases with physicians, we recommend that lease payments be determined in consultation with a third-party valuator. You can engage an individual or a firm that can look at leases in the area, determine what the going rate is for lease payments, and actually write an opinion letter or provide you with some documentation regarding what they consider fair market value to be. That will demonstrate not only what the fair market value is, but will also provide you with documentation showing that this has been determined by an independent third party, and therefore that helps with the arm's length negotiation of this.
And this is John. We just to add, certainly there's you could go through an appraiser, but many of the larger real estate organizations now have healthcare groups within them, so you could get a broker's opinion of market rents. So depending on what marketplace you're in, if you're in a larger metropolitan marketplace, there's several large brokerage entities that have healthcare expertise, so they can drill down to medical office rents.
Thank you very much, John. So we have one more question. Ned, this is actually directed to you, and they are asking, what kind of requirements are there for construction mini-perm loans? Is non-recourse possible for a physician group?
Yeah, that's a good question. I think in today's environment, to do a non-recourse loan, given the risks of construction fill-up and stabilization, we would require some outside support of the physician group. Obviously, it depends on the size and strength and profitability of that physician group, but generally speaking, our preference, and I'm not a real estate expert, but in talking to our real estate guys, I think we prefer to lend, to either a developer with more expertise in developing properties, or to that's where again the REITs can be a great source for not only for acquiring existing properties that are stabilized, but also for working with key developers to develop good medical office building projects, and our preference is to lend to a portfolio of real estate as opposed to the risks of a single property.
Great. Thank you very much. At this time, in the interest of time, we actually need to wrap up. I understand there are a few questions that have been submitted that we were unable to get to, but we will reach out to those individuals who submitted the questions and get you the information you need. So at this point, I would like to thank each of our distinguished speakers for presenting. The information was very informative and I think a very timely topic. And I'd like to thank all of the attendees for participating in today's web conference. So with this, I will say thank you very much, and I hope everybody has a great rest of the afternoon.